Welcome again. It's good to see friends again, and hopefully we will have a few more people joining us in the next few minutes. I don't think we need to remind anybody of the etiquette. You've been watching the slides, so I think we might get started. Anil, and welcome you, and thank you for presenting on this important topic, which I think we always need to revisit. Thank you, Anil.
Good afternoon, everyone. I was just saying to Odette that I might be a bit croaky today because I'm day 2 of my COVID infection, and so hopefully I will get through okay. So what I will do is just share my screen. Hopefully that's all visible now for you. I can see Odette nodding, so thank you very much. So yes, I've been asked to talk on this enormously large...
Sorry, Anil, are you able to make that into the full slide view? It looks like it's still in the down. Not to worry too much, but we're just seeing your sort of computer in the background, if you like. Can you see that?
Dr. Anil, if you could just press one icon is there towards the right and of your screen. There was one icon.
Now we've got your email screen, Anil.
Okay, just one.
Don't worry, there's plenty of time.
That's still no better, is it?
No, we've still got your email screen.
Okay, just one moment, sorry.
That's okay.
Odette, for your patience with that. So yes, so this is a very large topic, and I think that what I wanted to try to do with today's presentation is really concentrate on the aspects of opioid therapy that I have found to be particularly relevant when I have done my face-to-face Hamrahi visits. So this is very much, therefore, just one person's perspective on opioid prescribing. And so hopefully there will be some comments from you all as we go along. So clearly there's always the WHO ladder as a starting point. And I've just put it there for reminding, but I don't really think with the attendees today that too much of a reminder is required. So mild pain, non-opioids and adjuvants, mild to moderate pain, either weak opioids or atypical opioids, plus non-opioids and adjuvants, so plus step 1, and then step 3 being the more potent opioids plus step 1. So what I think that I had observed on a number of occasions was the mistaken idea that when commencing treatment with patients in pain, that we should start at step 1 in all patients and then progress upwards. But I suppose the misperception that can occur with the ladder is that it is a step ladder and that you start just at the lowest rung, then you go to 2 and then 3. In actual fact, if a person is reporting severe pain, then do not start at step 1, but go straight to the commencement of strong opioids together with step 1 agents. The WHO ladder, if we think about how it was developed and what the purpose of it was, it really is trying to improve pain management on a global scale. And the people who devised it are obviously taking into a range of a whole lot of different circumstances and prescribing practices. But over the years, what I think has really emerged, at least in my own mind, and again, this is just my perspective, is that there is, for cancer-related pain and the patients that we are seeing, there is very little justification, or in fact, no justification, except in exceptional circumstances for step 2. So I think that going straight through to the prescription of a potent opioid in the vast majority of patients is actually appropriate. And I think that we need to always remember that what is the problem that we are trying to manage? And realistically, it's twofold. One, it's under recognition of severe pain, but also it's the under prescribing that occurs. And so going through the step ladder will put us at risk of that. So with morphine as being the original opioid recommended, it was not recommended at the time on analgesic superiority, and in fact, over the years, as more research has become available, we don't necessarily have evidence for any opioid being superior of one over the other. There are clearly individual circumstances for maybe either the jurisdiction, so which country where the opioids are being prescribed, what the availability and the cost might be. Also the local factors. So in that, I know that in my practice here in Australia, there's a particular preference for oxycodone, for example, as being a first-line opioid, and that's the culture that has developed in the hospital where I have worked, but that's not based on superiority. And so at least in India, very much it should be based on a combination of both availability and cost. And so therefore morphine is very appropriate. Contrary to perhaps some perceptions, in patients with neuropathic pain, there still may be a role for opioids. And so not every patient will actually require a neuropathic analgesic. And it is often reasonable, if nothing else, just to try to keep the pain management plan as simple as possible for that patient, to try to limit it just to the lowest number of medications possible. Just with regards to the same as in terms of the analgesic effects, in terms of adverse effects, it is hard to say that one opioid is necessarily superior to another. Certainly there are real problems with morphine, which I will talk about in the next few moments. The first one is very much the large intra-individual variation. And so here what I'm referring to is that we can never predict how one person is going to respond to this opioid, or in fact any other opioid. And I think that it's a useful practice to get into is to actually explain that to the patient and the family members, that yes, every time we see someone in your situation, it is a challenging process, that we need to start with this, and then we will have to reassess and monitor you for side effects and consider other treatments as appropriate. The second potential problem is how it is metabolized and excreted. So particularly it's the excretion of the active metabolites. So morphine 6-glucuronide, which I've abbreviated there to M6G. There's a relatively small percentage of that which is produced, but there is a significantly larger production of morphine 3-glucuronide. And unfortunately, it is that M3G that can contribute to some of those side effects when the M3G is retained in renal failure or renal impairment. So the drowsiness, cognitive impairment or delirium, and myoclonus. Morphine and all other opioids will have the same effect on the gut. So the intestinal transit time will be increased and constipation is near universal. So we need to, when the hand that prescribes the opioid prescribes the laxative in effect. In places where slow-release morphine may not be available, so the practice will often be to prescribe 4-hourly morphine or 4 times a day morphine. But in that situation, it would be appropriate to prescribe a double dose at bedtime to minimise the risk of the patient waking up, not only overnight, but in particular in the morning with pain. The breakthrough dose or the SOS dose should be adjusted in proportion to the total daily dose. So as we increase the dose, then the as required dose should also be increased. And the rough proportion would be somewhere in between 1/6 to 1/10 of the total daily dose, but that's not an absolute figure. There may be some variation in that. The literature can be very confusing, and I certainly remember when I was starting as a junior doctor in palliative care, I actually found myself tying myself in knots as to work out whether to convert from oral to injectable morphine on a 2-to-1 or a 3-to-1 conversion ratio, because it really did seem that the literature was dominated quite heavily with support for a 2-to-1 conversion. I have chosen myself to adopt a 3-to-1 conversion in practice, particularly because when I'm giving an injection, it's usually when the patient has already been started on oral morphine and then going to the injection dose, maybe because they are not able to take the medication orally, or maybe there might be an episode of severe pain. At least that 3-to-1 conversion allows for a numerically lower dose, which hopefully will minimise the risk of an inadvertent excessive dose being given for that person. But obviously, again, individual variation does occur. I think it's important to always remember this situation, or this concept of the principle of double effect. And I think sadly, this has really influenced opioid prescribing quite significantly. So this is one of the ethical principles that we, most of us have learned. So just as a reminder, the action itself must be either morally good or indifferent. And so in this case, the action is the prescription of opioids for pain. Only the good effect, so therefore pain relief, must be what we're intending, even though we accept that there may be a secondary effect, which is the shortening of life. The third component of the principle of double effect is that we should not achieve the good effect, so we should not achieve pain relief by way of the secondary effect, so by in effect ending that person's life. And obviously the good effect must outweigh the secondary effect. So clearly, pain relief with opioids, we could be led into this sense that perhaps the principle of double effect may come into our consideration. Unfortunately, this is a real problem. And there are repeated references in the literature and also in the medical curriculums. And I think both in Australia, but also in India, we see that there is repeated references that opioids can either definitely or potentially, either potentially or actually hasten a person's death. But then we then say, well, that's okay because we're only prescribing the opioids using this ethical principle of double effect. But in actual fact, we need to ask ourselves the questions, do opioids shorten a person's life? And really what we're talking about is, do they cause respiratory depression of such an extent that it will cause that person to die? And so I think that that can be convincingly refuted. Opioids do not cause respiratory depression if they are prescribed appropriately for the correct patient in the correct dose. And our evidence for that is that a lot of the concerns about respiratory depression is in a population of patients not that we are seeing. So this is in patients in particular with substance use disorders. So that's the term that we use here in Australia. So the other term that you may be familiar with would be drug addicts. And we know that people who inject opioids are at risk of dying from respiratory arrests. Secondly, those in acute post-operative pain, but those patients have also received anaesthetic agents as well, and so they're more vulnerable from a respiratory perspective. And thirdly, healthy volunteers. The second source of information is opioids prescribed for those with chronic cancer pain, and the literature is very clear here that they are safe. And thirdly is our own personal individual experience. And hopefully you yourselves have noticed this as well, that opioids can be prescribed safely and it does not cause the person to die. However, we will often be at the receiving end of comments from our colleagues who will say, but you need to be very careful because opioids can cause a person to die. Odette, yes.
Look, Anil, I think that's such an important point. I wonder if it's worth kind of pausing a little bit and asking people, perhaps for some of their experiences in India or in Australia as well, around being challenged about using opioids for the reasons you've raised, and how people handle that, because it can put you in quite a difficult position as a clinician when all those around you are looking at you very worriedly. I can see Tara nodding, and especially when you're just starting off in palliative care practice and you're perhaps the only person who's willing to prescribe opioids for the patients. It can be pretty scary, really. I just wonder what people's experience has been, and also the Australian clinicians, what you also have encountered in this. Is that all right, Anil, if we break to just ask, invite some conversation about that?
Thank you.
So, Dr. Mishra, maybe in your practice in Patna, has it been difficult have you encountered a lot of concern about opioid prescribing at Mahavir?
Yeah, good afternoon, ma'am. We have a lot of concern. Our colleagues think whether it should be kept reserved for severe pain cases, and they wait through, like Dr. Tandon said, that we should move directly to the low dose morphine for quick effect. But they follow WHO step ladder pattern. They first start with the non-steroidal anti-inflammatory drugs, then go through to the weak opioid and adjuvants, and then reach to the level of that to start in the low dose. So we get usually we get effects of pain relief very late, and patient really in pain and other problems such as the burning sensation and other problems related to the palliative care for a long period.
Thank you. So that's what Anil was sort of saying. I think we've all seen that in India, and often many times patients don't get beyond the second level because of the fear of prescribing opioids or the difficulties in obtaining stronger opioids. Anil, do you have any comments or others on that?
No other comments, but I suppose, I've seen some non-palliative care prescribers in India really speak very strongly, and sometimes it can feel quite threatening for the palliative care doctors when our colleagues are saying, no, this is dangerous, what you are doing, and trying to explain to them the literature and the evidence to support the safety is a conversation that takes a lot of time, but it's important to invest that. And if they don't believe you, then to show them the journal articles that show that it is actually safe.
And Dr. Kale has mentioned that he would start morphine if the pain score is above 7. Would you agree with that, or would people have a different threshold? How do people approach that? And how useful do you find the pain score, numerical rating? Dr. Kale, do you find that patients are able to score the pain quite well using the numerical rating? You find it a useful tool?
Yeah.
Yeah,
ma'am. We do. Whenever we first encounter any patient, we do thorough clinical examination of that patient and always mention the visual numerical pain score, and prescribe medicines accordingly.
okay.
I think Dr. Kale has raised a very important point about, though, at what point should opioids be commenced. And so clearly severe pain would be, in effect, a pain score at approximately 7 or above. I think, though, that in the context of, it also does depend on the context of the patient and their history. And so if their background history is that they are a person with advanced cancer, and we can expect that the pain may, as their disease progresses, may get worse, even if they had a pain score of less than, even if they had a pain score of less than 7, so even a pain score that might be only moderate pain, so 3 or 4 or 5 out of 10, it may be appropriate to commence opioids at that level. And that is certainly my practice.
Thanks, Anil.
Yeah, if I may say, I think it's that important where educating clinicians is so important here, because I've noticed and I've also learned from doctors in Bhutan that the fear they have in prescribing opioids is more of patients becoming addicted to it. That's one of the fears I was told they have. Even a doctor, a specialist who got trained on palliative care, who had an idea about palliative exposure, treating patients, palliative care patients, he still struggled to use morphine in Bhutan because none of the other colleagues were comfortable using it. So I feel how important education would be in changing that trend and helping them understand how important it is. Because if the doctors and clinicians don't feel comfortable, then patients are obviously not comfortable. Even if they have pain, they are in more fear of using morphine than not to. So that's where I feel how important education is.
I think so, Tara. And if I could just cut in briefly, Anil, that I think that's why this sort of community of practice that we're trying to develop through these ECHO programs is really important, because it can be very isolating, actually, to be working in the field of palliative care and trying to prescribe opioids when others are very nervous about it. So at least you can get on the WhatsApp group, or you can connect to Dr. Mishra or somebody and just sort of get somebody else to say, yes, I think you're doing the right thing, can be quite reassuring. Anyway.
So I think I would like to just move on from the topic of the respiratory depression. You've all presumably had a chance to read those notes there. And then I'll just very briefly cover some of the other opioids. So fentanyl patches, unfortunately, my understanding is that they are very expensive in India. And so it would only be in very specific situations that one might want to consider their use. And so it perhaps may only be either in the setting of someone who is unable to swallow oral morphine, or because of the lack of active metabolites of fentanyl, and if they were intolerant of morphine, then it may have a role in the patient with renal failure. It is said, and the drug company representatives are very keen to tell us about the reduced constipation with fentanyl patches, but I do not think that that should be the sole reason for selection. As a approximate dose conversion, so this is potentially a conversion there. So I think that it's the 25s and the 50s that are commonly available in India. So 50 microgram per hour fentanyl patch is therefore very strong and represents in the order of around about 180 milligrams of oral morphine. There's a wide range with that figure, but it's just important to remember how potent fentanyl is. I'd like to just briefly mention tramadol and tapentadol, because again, I think that that's something that may be best used in the non-cancer pain population. So very commonly in our hospital, it's used in patients post-operatively or with acute pain. But prescribing morphine would be a better choice in our population. So I've just written there some approximate dose equivalent ratios. And so for tramadol, potentially somewhere between 1/5 to 1/10 of the morphine dose. And for tapentadol, which I'm not actually sure if that is available in India, but if it is, then a dose equivalence of 1/3 to 1/5 of morphine. Buprenorphine, I certainly have seen prescribed in other patients in India. There are one of the advantages for buprenorphine, and where I see it used commonly in my hospital, is because of its reduced risk of respiratory depression. But it is a patch. So the tablet is not absorbed by the stomach, and so that's why the transdermal route is required. It is useful in renal failure, and I think that the 5s and the 10 patches might be what is available in India from what I had seen. And so the approximate conversion that I use is to take the numerical value of the patch and then double that as a rough gauge for conversion to morphine. So a 10 microgram per hour patch might be approximately equivalent to 20 milligrams of oral morphine over 24 hours. And my last slide is, I've just already alluded to or specifically mentioned renal failure, but I think that liver failure is worthy of mention. Unfortunately, there is no ideal opioid in patients with liver disease. And clearly there is a very great risk in prescribing opioids with liver failure of causing drowsiness, or in particular in patients with cirrhosis, the risk of hepatic encephalopathy. But so the general principles really would be my recommendation here. So starting at a low dose, looking at longer dosing intervals than you might use for a patient with normal kidney and liver function, and then to avoid codeine, because codeine's analgesic effect relies on the conversion in the liver to morphine, and so this will be impaired in people with liver disease. I'm going to stop there, and I will stop sharing. And again, happy to hear any comments, or even, and I think in particular, just other practices that people adopt.
I presume you didn't speak about methadone because we covered it last session, but maybe, do you want to say a word just in case people weren't there last time, off the cuff? Is that all right? Thanks.
Yes, absolutely. Thanks. So the brief comments that I can give about methadone is that it is a very useful medication, I think, in the Indian situation for patients who are intolerant of morphine or have had an adverse reaction to morphine, and starting at a low dose would be appropriate because of its high potency. So a low dose may be as little as 2.5 milligrams twice a day. Because it has a very long half-life, the risk of accumulation occurring is a problem that could be quite delayed, and so may not occur even within the next 1, 2, or 3 days. And so it would be appropriate to avoid dose increases in methadone for at least 5 days, if possible.
Thanks, Anil. Would anybody else like to comment on either your own experiences or questions that you might have for the group? I wonder if, here we are, thank you, Dr. Shibari. So Anil, can you see the question in chat? Morphine has near to no effect on chronic alcoholic patients. What can be done in that case?
So I suppose I would suggest that actually morphine can actually be effective as an analgesic in people with chronic alcoholic liver disease. And it may be that, I mean, I would be interested to hear your perspective, perhaps, Dr. Shivhar, about that, because the pharmacology, at least, of morphine is that it still can work in people with liver disease.
Dr. Shiva, are you able to give us a little more of your experience on using morphine in patients with chronic alcohol or cirrhosis? It sounds as if it hasn't worked terribly well in your experience. Do you like to talk about that?
Yeah, a very good afternoon to you.
Hi.
Hello. Actually, ma'am, we are practicing here. So it's just that due to chronic alcoholic patients, they are having near to no effect of morphine in them. So we start with 10 mg morphine 4 hourly, but the effect of morphine is not that much that we should get in for pain relief especially. We have not started using methadone actually. We are surely looking forward for using methadone.
And do you think that the pain that they were experiencing is related to, for example, is it pain that is due to cancer, or is it a non-cancer pain in that person? For example, musculoskeletal pain, or perhaps abdominal pain from ascites?
I think, sir, there is, the mixed combination of pain. Like sometimes there is, the pain can be associated with mental stress also, psychological pain. So you get mixed signals of the pain in that case. So it can be related to cancer, it can be related to mental pain, or not related to cancer also, like muscular pain or cramps or abdominal pain. It's like that.
And I think the challenge is always to try to, in our history and examination, identify the actual cause of the pain and the mechanism by which it is being produced, because for many patients, opioids may actually not be the most appropriate class of medication. And so for non-cancer pain, simple analgesics, anti-inflammatories may be more appropriate. Or for the bed-bound patient, non-pharmacological measures such as either a hot pack or a massage may be helpful. Or
Dr. Shiva, you.
Pardon?
You are obviously very appropriately mentioned psychological pain as well. And so, yes, clearly in patients, there can be multiple different mechanisms by which they're experiencing their pain, and it can be very challenging. And we need to obviously accept that one drug is not going to be the solution for people with multiple mechanisms for their distress. But for what it's worth, I would encourage you to not be disheartened about the prescribing of opioids if there is actually physical pain in a person with liver disease. There would be still justification for a trial of that.
Yeah. Anil, would you be up to continuing with the cases? Would you like to move on to that, or would you like a break and come back to that?
So now, yes, I'm happy to. This is now a little bit awkward, Odette, because I thought that the cases then would be only discussed each or within the breakout rooms.
Oh, we can do it that way. That's fine. That's fine. Except I'm not sure if we've shared, well, 3 or can we make the cases visible to 1 case per group? Were you thinking, Anil?
Yes, but
Sure.
is that not technically possible?
If you want breakout rooms, we can arrange that, Dr. Anil.
We can have the breakout rooms, but can we have the cases shown in each of the breakout rooms, or how can we?
If it is okay for you to present the cases in chat, we can do that. We can enter each one of the breakout rooms and put the cases in the chat so that the participants can view them and discuss about them.
What should we do? Anil, would you, you have the cases, don't you? At Pallium, you have them? I think Anil did share them.
Yes, I did. And so unfortunately, the cases are quite long.
I think because we're a relatively small group, maybe we start by having at least one of the cases discussed in the group, and we see how we go. If we're not getting enough discussion, we can try, and that might give Pallium time to write the cases. Maybe you could write the cases into the chat anyway, or load them into the chat, and we can just start by talking about the first case as a group. Anil, would that be all right?
Sure. So what I can do,
So for Pallium, would it be better to give you a little bit more time to do that, and we could have Dr. Mishra's presentation next while we're getting the cases organized?
Sure, you want the cases to be displayed in the main group itself or in breakout rooms? I just wanted to.
Sorry. Maybe you could put all the. We were thinking perhaps have 1 case in the main group, and then the other cases available for breakouts. So that would just give you more time to write them up. I don't know, what's easier for you?
Okay.
Okay.
So we can start by having a conversation about case 1, and then maybe
So I have just shared, I'm not sure if that's visible.
We're back with your inbox, Anil.
Oh, right, okay. Sorry.
That's okay.
Everyone.
That's okay.
Should I just read through the case then?
Okay.
So this patient is an elderly man with squamous cell carcinoma of the oral cavity, and how he presents with locally advanced disease, and he has an orocutaneous fistula. He has pain on swallowing, minimal oral intake due to the pain, bleeding from the wound, as well as constipation. When first seen on the morning ward round, he was on a combination formulation of an anti-inflammatory and paracetamol, so diclofenac and paracetamol. But the problem with that was that the total daily dose of the paracetamol was actually subtherapeutic. So we recommended a number of changes. We advised cessation of the diclofenac because of the bleeding that he was experiencing, knowing that the diclofenac would impair platelet function. We recommended therapeutic doses of paracetamol, so 1,000 milligrams QID, and then tramadol 50 milligrams as required. We then reviewed him again later that same day after we had initiated that plan. But he said to us that the pain was like someone was hitting a hammer to my head. And so we then commenced him instead on slow release tramadol, so that at a dose of 100 milligrams twice a day. When we reviewed him the next day, unfortunately, he was continuing to experience severe pain. So we recommended the cessation of the tramadol and to commence morphine at a dose of 15 milligrams 4 times a day and 15 milligrams as required. Over the subsequent days, he actually then said his pain was generally well controlled. He was able to eat more because his pain was under better control. And then on the final day of our trip, which was on day 6, he said he was actually prepared to be discharged home. So I think that it would be nice to hear some comments about what happened for this gentleman and how we approached his severe pain. Anyone else, either in India or in Australia, like to critique my practice, my Dr. Tandon's prescribing practice? As you can see, hopefully you can pick that I actually did the opposite of what I had actually said in my presentation. And so you can see that, so this was a case that I actually, a real patient that I looked after. I haven't changed any of the details. And this was a patient that I looked after in 2010. So 12 years ago, on my very first visit to India, to Jamshedpur it was.
So Anil, what was the context then? Well, for changing your practice at the time compared to, how did that impact on your choice of analgesics?
Sorry, do you mind asking that again? I didn't quite understand it yet.
Yeah, I'm wondering, as you say, you would normally perhaps go to strong opioids earlier. Was it a question of lack of availability of opioids, or was it?
Yeah, so absolutely, Odette, you've really highlighted the critical issue here. So this person had severe pain, and so what I did was that I did go to only step 2 in the WHO ladder. And in actual fact, I remember very distinctly why I did that. And it was because even though it was my first day in this hospital in India, I already had experienced a lot of concerns from my colleagues that I was working alongside with about how freely, in effect, I seemed to be recommending the prescription of morphine. And so I myself found that I was becoming morphine phobic. And I just, for some reason, I forgot all of the theory that I knew and that I had learned, that in severe pain, one should prescribe strong opioids. But it was because of the influence of the colleagues that I was working with, the culture of the hospital, that I felt that I could not actually prescribe it. And so I did then succumb to prescribing tramadol. And then sadly, the patient had to go through an additional 24 hours of uncontrolled pain before it became clear to me that I had to prescribe morphine for them.
Yeah. And also, as you say, your first day there, you were trying, you don't want to make an error either, and so you do become very careful. David, do you have any comments on this? Because you've been in similar situations, I'm sure, in India, where you've been advising on analgesia at Kachar. And the Kachar team are here, they can comment.
Well, thank you, Odette. Yes, I have had exactly the same experience, and that anxiety and fear returned on the first day or two. But fortunately, the situation in Kachar was that morphine was already being used, and we had to fine-tune its use, but not to begin it. So I haven't actually faced exactly that same problem. But I can certainly sympathise with Dr. Tandon and in that situation, because it makes us look as if all we do is prescribe morphine. But I guess in situations like that where it's not being used at all, then that's inevitably what will happen. And using it, advising it for many of the patients is to be expected, really, isn't it?
Yeah, exactly. Would anyone from Kachar like to comment on this and how your confidence with using morphine has grown over the years? I'm not sure who's here from the Kachar team, whether it's the doctors or nurses, but or any of the other doctors who have started to prescribe morphine, whether you would like to comment on how you have gained confidence? We'll be hearing from Dr. Mishra soon, I guess, about their practice. So we'll be hearing some good examples of that, I guess, in the next section.
Yeah, ma'am, we are also prescribing morphine at 4 hourly or 6 hourly interval, and also prescribe PRN dose once the patient has 1 hour after the previous dose. So we also prescribe in the same.
And how many prescribers are there now at your center, Dr. Mishra?
Actually, ma'am, we are only 2. Because of the opioid narcotic abuse, our administration has, and in this part of country, our administration has restricted this only to 2 persons, Dr. Rita Rani as unit in charge and me as a consultant palliative care physician. We are only allowed to prescribe these morphine and fentanyl, and proper, we have to maintain all the records at our center as per Narcotics Control Bureau of India, guidelines of the Narcotics Control Bureau of India.
So can you see, well, we might talk about that a bit more in your talk, but I know you have a very large number of patients coming through the centre. So for two doctors, you know, for a large cancer centre, that's a big ask for the two of you.
Yeah, ma'am.
Anyway.
Should I present my PPT?
I'll just stop sharing this one. Sorry, Dr. Mishra, the Pallium India team have managed to get the cases ready for the breakout rooms, I think. Is that right, Raju and team?
Yes, Dr. Audit, we have the case presentation, but we do have a concern, like we have only around 13 to 14 participants for today's session.
Yes.
So how do you think we can go forward with it?
Look, maybe we just do two of the cases, and if we can have some of the Australian and a mix of the Australian and Indian participants so that we have some good discussion in each of the groups. Would that be possible?
Yes, Doctor. So we can move on
And
with second case and the third case. We will split the entire group into two groups.
Into two. And then can people maybe have Anil in one group and I can be in the other group, and we'll just spend 10 minutes perhaps so that we leave plenty of time for Dr. Mishra's presentation and discussion. Is that okay?
Yes, it's okay, ma'am. So
Lovely,
give us a few minutes. We will make it into two groups soon.
Okay. Okay, thank you. Just when you're ready, just we'll go.
What time would you prefer? 5 to 7 minutes would be good.
Yeah, maybe 7 minutes.
Okay, good.
Thank you. Okay, so Dr. Kale has written something in the chat for morphine 4 times and not 6 times as it's usually done. You're asking why only 4 times for Dr. Anil's, Dr. Tandon's case, is that right, Dr. Kale? Yeah.
And so in that, I think that that's a really good question, because obviously 4 times a day is then not necessarily going to have the appropriate time interval. So the time interval may be actually longer than 4 hourly. It might be even closer to 6 hourly. The problem here is obviously what is going to be manageable for the patient to comply with, particularly when they leave hospital. And so trying to balance the pharmacological justification, or what might be correct, as against what is practical. So yes, 6 times a day would be potentially appropriate, although if we look at the 24-hour clock, at least one of those doses may then be in the middle of the night, in which case then it would be perhaps adjusted by then giving the double dose at night time. One of the biggest problems when a patient is seen in follow-up is always to remember that when a person does continue of ongoing pain, despite our pain management, we should always just check that they have understood our instructions and that they are complying with our instructions, because I think that we all just need to think about what we've done ourselves when we've been sick. How good have we been at taking tablets? And I don't think any of us are saints in that respect.
Thank you, Dr. Anil. Dr. Anil, can we split into two groups right now?
Yes, wonderful. Thank you.
So we'll be having 7 minutes of discussion in the group. Make sure you make it more in the most interactive possible for you. So at the group, we will share the screen which shows the case to be discussed in that group.
Okay. Let's see how it works. Thank you. the other breakout. But I hope the discussion went well. I'm conscious of time, so perhaps we can take perhaps a minute from each group, somebody just to give some feedback about the discussions in each of the groups. Would the group that you were in like to comment on your discussion, Anil, some of the issues that came up?
So just very briefly, we were just discussing the management of a lady with metastatic breast cancer and severe chest wall pain. And when initially seen, she was taking a combination preparation of tramadol and paracetamol. And so our discussion really was just very briefly about the very low dose of tramadol in that combination preparation and the need to separate out the two drugs, separating the opioid from the paracetamol, so that at least we can still give the paracetamol at therapeutic doses, but then because of the severe pain, going straight to morphine rather than titrating the tramadol.
Great, thank you. Dr. Kale, would you like to give some feedback from our discussion? I know your reception isn't so good, but...
No, what I said was, if we want a quick relief and the morphine, whatever dose we are giving is not responding, then the ketamine stands as a choice. Even because the patient who had a suicidal tendency and he has a very short life remaining. So ketamine definitely helps in such situations. This is my opinion, personal opinion.
Great. Thank you. So we were talking about a 16-year-old boy with a nasopharyngeal carcinoma who had opioid poorly responsive pain and had to have aggressive up titration of his morphine, but still with severe pain. So we started talking around other ways you can manage that pain. All right. Dr. Mishra, would you like to present your experiences at Mahavir in Patna about opioids?
Yeah. Definitely, ma'am. Thanks for inviting me. And I'm sharing my screen. So my topic is opioid availability issues in Bihar. And I'm presenting, these are the slides prepared by Dr. Rita Rani, whose dynamic leadership led to the development of palliative care unit at our center, that is the Mahavir Cancer Sansthan, Bihar. Now, Bihar is the third largest state by population in India and 12th largest by territory with 38 districts with an estimated population of 127 million by 2020. It ranked second in terms of the tobacco consumption related cancers, and the burden of new cases is rising every year and would further increase to 136,000 cases in 2026. It has 86,000 cases in 2011, making it fifth most common cancer affected state of India. Now, history of palliative care in Bihar. The initiative for palliative care was taken in 2005 for the first time by IJIMS Patna in collaboration with WHO, who provided around 5 lakhs of morphine tablets here. The morphine tablets, so the morphine tablets are available here since 2005. The major boost to the palliative care facilities occurred after the healthcare providers from state attending CTC2 and CTC3 program, a joint venture of AIIMS New Delhi and Asia Pacific Hospice Palliative Care Network, as part of implementation under the National Program for Palliative Care by the government of India. So the major care providers for the palliative care at present in Patna are IGIMS, Mahavir Cancer Sansthan and Research Center, AIMS Patna, apart from the Homi Bhabha Cancer Research Institute at Muzaffarpur. However, several oncologists not practicing in above mentioned hospitals are also prescribing the opioids and other supportive measures to the cancer patients and other patients requiring palliative care. Now, happy to be the part of Hamrahi project. These are glimpses when for the first time we started palliative care unit at our center. We ma'am can see her photo with us. This is the how it was the palliative care before the pre-CTC3 training. It was started on 14th of March 2018 with the help of Jeevdaya Foundation. Now, journey of these are how we gathered together to start OPD at Mahavir Cancer Sansthan. See, my director, Dr. Biswajit Sanyal, is taking so much of interest, and Dr. Rita Rani as unit is discussing the issues with the unit as a unit director, unit chief of the palliative care. Here we are with the Susma ma'am for starting palliative care in full-fledged form. Now, the lessons, what we learned from the CTC3 training. Firstly, the implementation of palliative care services in a structured manner. Earlier, we had OPD, but the palliative care services were not in the structured manner. Team making and capacity building, the power of sharing knowledge, and enhancing the communication skills with the patient and the attendants for the better symptomatic management. Good prescription writing was also issues at that time, and the proper storage and dispensing of the opioid analgesics. So these are the glimpses of initial days when we started our OPDs in the Mahavir Cancer Sansthan. Then this is the glimpse of our IP indoor wards, palliative care ward. We have at present, we have 32 bedded palliative care unit at our center, and which is dedicated to the patients for palliative care only. Now, this is our palliative emergency and OPD unit, where we attend the patients coming from remote areas of the Bihar, with especially cancer patient with so many of the palliative emergencies, including the pain, including the severe pain. Now, we have 1,084 palliative care cancer patients and the cancer patients. Number of new patients in the IPD is increasing every day, and at present it is about 2,857 patients in the as our records in the 2021. Initially, it was only 293 patients. Opioids. The opioids available at our center are injectable morphine and transdermal oral and injectable morphine, and the transdermal patches of fentanyl at the nominal cost. We are also having tramadol and tapentadol at our center. The dispensing site for the opioids is mainly hospital pharmacies in Patna and Muzaffarpur. The drugs are also available, especially transdermal fentanyl, in some of the private pharmacy stores, and limited access to the opioids has unfortunately resulted in the patients needing to travel to far off distance to procure opioids So our aim here to start home-based palliative care so that they can easily get the opioid analgesics. Now, the opioid availability at our center. The morphine has been available in our hospital since 2005. We have immediate release morphine, 10 mg and 30 mg formulations, fentanyl patches 25 microgram and 15.5 microgram, pentaweek opioids, tramadol and tapentadol. These are also available at our center. Morphine consumption of our hospital. This is 5-year data. We can show in this data that the blue bar is showing 10 mg consumption and red bar is showing 30 mg consumption. So definitely the consumption of 10 mg morphine immediate release morphine tablets is more than the 30 mg. And this is the total number of 10 mg tablets dispensed till now is the 316,811 tablets, and the total number of 30 mg tablets dispensed is the 294,802 tablets. Dose requirement of the patients at our center is maximum is the 60 milligram. Most of the patients are relieved by the 24 hours 60 milligram tablets, and followed by this the 30 milligram tablets. This is also common commonly prescribed dose. So what our colleagues think about opioids at our center, because this is one of the concern in prescribing morphine at our center. They keep it reserved for severe pain. The first issue is this, that they do not send patients to us for prescribing morphine. Commonly, they advise tramadol at regular intervals and prescribe morphine as PRN medicine for the unbearable pain. And this is commonly I've observed in wards at our center. They are afraid of its side effects. Most often they say this patient will become addicted. So, and if prescribed, mostly it is underdose or inadequate prescription. So these are the issues which we are still facing at our center. The new joining medical officers and also some of the specialists are afraid of prescribing morphine. So prescribing, after the development of palliative care team at our center, prescribing opioids for us and our team is easy. We have adequate supply from the management, and dispensing of the opioids is also channelized at our center nowadays. What percent of patients at our center have poorly managed pain? Because this is frequently asked question. So the more than 95% of the cancer patients in our state, that is Bihar, have poor management of the pain. Reasons being lack of availability of opioids, lack of knowledge of opioids by the healthcare professional, and opiophobia, that is prescribing these medicines will lead to the drug dependence. This is also a big issue in our part. So the national program for the palliative care, what the government is doing. The palliative care is part of Mission Flexipool under National Health Mission. Beneficiaries are terminal cases of cancer, AIDS, and chronic diseases, etc. The goal is availability and accessibility of the rational quality pain relief and palliative care to the needy as an integral part of the care at all levels in alignment with the community requirements. So the objectives of the national program for the palliative care is to improve the capacity to provide palliative care services delivery with government health program, such as national program for the prevention of control of cancer. So the NCPD is the inclusion of the national program for the palliative care is essential in the in the National Program for Prevention and Control of the Cancer, NCPDS program. So the support implementation to ensure access and availability of the opioids, encourage attitude shift among the healthcare professional by strengthening and incorporating the principles of long-term and palliative care into the educational curriculum, promote behavioral change in community through increasing public awareness and improved skills and knowledge regarding pain relief and palliative care. Policies. Though the state of Bihar does not currently have a state palliative care policy, but the meetings were held in 2019 for pain and palliative care policy under the non-communicable disease cell by the Health Society of Bihar. It is still must take safe in order to implement better far and wide in our state. So we have attended. To advocate this, we have to create a lot of community awareness among the doctors and awareness among the patients and attendants and other health care professionals. So to promote this, we have attended workshop for the palliative care, delivered lectures on the palliative care, various lectures by the palliative care teachers, doctors, nurses, staff, and caregivers. We have organized sensitization program at our center and also to the healthcare volunteers. And in most of the cases, our target audiences are the doctors, nurses, paramedical staff, and public. So you can see the glimpses of some of the our sensitization program. This is the volunteers training program, glimpse of volunteers training program. This is she is doing some mono act play to show the good communication skill among the healthcare professionals, including doctors, paramedical staff. These are the postgraduate students listening to Dr. Rita Rani how to prescribe medicines, opioids, analgesics. And this is also one of the community awareness program at our center. We have arranged training program, volunteer certificate course on the palliative care for common community volunteers through IAPC on 6th and 7th of the July 2019. The target audience in this case were housewives, students, physiotherapists, dietitian, radiotherapy technicians, and other paramedical staff who are attending the patients at our centers, and also from outside. The total number of the audience was 30 at that time. This is also the volunteer certificate training program, glimpses of volunteer training certificate training program. You can see here the Susma Bhatnagar ma'am and Biswajit Sanyal, and we all the doctors and paramedical staff of the Mahavir Cancer Sansthan and the nearby community healthcare professionals. Any ma'am. So these are the end of Life Nursing Education Consortium training at Mahavir Cancer Sansthan, and these are the pictures of EAPCON 2021 workshop for social workers and volunteers at which we organized at our center. Now, what are our future plans to promote palliative care and at our center, and also promote palliative care at the grassroots level? Our planning is to start with the home-based palliative care services, DNB in palliative medicine for the teaching and training of the postgraduate students, pain-free, to establish pain-free hospital and training center for the palliative care. Now, we are facing a lot of challenges on this. The challenges are limited availability of opioids in Patna and Muzaffarpur has resulted in patients having to travel a quite distance to procure opioids, which is integral part of the palliative care. Further expansion of palliative care services is deterred due to healthcare providers due to lack of awareness among the healthcare providers and lack of effective management of both malignant and non-malignant life-limiting diseases due to inadequate training of the healthcare professionals and caregivers. These are the cases. This patient, 50-year-old male, presented with severe pain, case of CA lower alveolus, post-op, post-RT with local recurrence and lung mets, bony mets, had received multiple lines of chemotherapy. The pain was not only due to the physical pain, the patient has a lot of other pain also, emotional, psychosocial issues also, and the financial issues also. The patient had wife and 3 children, and was worried to know about his life. He was also wanted to know about the immunotherapy. So these patients, all these are there. We have a lot of such type of patient who need adequate palliative and supportive care at our center, and we definitely try to cater them at our best. This is another case. So we are trying our best to make them happy. You can see in this picture, this father and daughter, this patient, this little child of leukemia. We are trying to make them happy and pain-free. So thank you. This is our palliative care team at Mahavir Cancer Sansthan.
Thank you so much, Dr. Mishra. You're doing wonderful work at Mahavir, you and all the team there in clinical work, in education and training and advocacy. And I think Mahavir is really emerging as a very important hub in the northeast.
Thank you, ma'am. Thank you.
Yeah, I think you're going to make a huge impact. The way you're developing and the model you're as a training center as well. So congratulations on all your achievements.
Thanks, thank you.
Can I ask you, like when we talked with Dr. Rita a few months ago, when she presented some of this data, then we also talked about the advocacy to the state drug controller. I think Mahavir, as you say, Mahavir and one other centre outside of Patna are really the only 2 places that are really providing morphine to patients as abundantly, if you like, as you know, as you're doing. I'm not sure if IGMS or AIMS have really achieved the same sort of penetration, if you like, of pain relief. Or can you comment on, I don't mean comment so much on the other institutions, but just on how the availability of morphine is developing across the state of Bihar and the work with the state drug controller.
Madam, morphine is available only in Patna and at Muzaffarpur. In Patna, it is available at Mahavir Cancer Sansthan, Indira Gandhi Institute of Medical Sciences, and AIMS. And at Muzaffarpur, they have started dispensing this morphine at Bhumi Bhabha Cancer Research Institute.
Yes. There still seemed to be some confusion, though, whether the state policy had come into line with the amended...
No, ma'am. They are planning to start a few months ago. One of the State Health Society member called us for training of the healthcare professionals at grassroots level. But they, because they said that we are going to start this national palliative care policy under the umbrella of NHM, National Health Mission. But we don't have any government policy at present.
Not the policy, but what about the single license for opioid prescribing for an RMI? Is that now been instituted at state level?
Yeah, we have received this from the drug controller of state drug controller department.
Okay, so maybe some progress since we last talked on that.
Yeah.
Tara, you were asking a question in the chat. How supportive is the Bihar government in strengthening palliative care in the state? I think you're saying that they are supportive in running and implementing the National Palliative Care Program more widely across the state of Bihar. Is that correct?
Yeah, they, pardon, ma'am?
Can you see the question in the chat?
Yeah. I can see how supportive is Bihar government. Yeah, Bihar government is supporting. Bihar government is supporting, and they are planning to start, because we are losing fund also. They are saying that the central government is sending fund for us for the strengthening of the palliative care center. And to spreading to the grassroots level, but they have not yet started.
Yeah. Okay. So plenty of work ahead for you.
Yeah.
Plenty more. Any other last comments before we need to wind up?
One of the comments about the opioid prescribing barriers there was the fear of dependence. So that's obviously something that I didn't comment about. So thank you, Dr. Mishra, for raising that as a barrier.
So this is very frequent in our, because they think this is something narcotics, and once we'll start taking, will become dependent on this, pain will not go without taking this. So they don't have fear that will suffer from pain. They have fear of drug dependency. Even patient says, leave it, will give me some IV diclofenac or tramadol, don't give morphine. Even patient says an hour. So we have to counsel patient also. We have to create awareness among the doctors, among the patients and our attendants also, that we are giving for the relief of pain.
Dr. Mishra, hello.
Thank you.
Yeah.
Dr.
Yes.
Mishra.
Yeah.
Dr. Khalid from Nagpur. You said your doctors are apprehensive about prescribing morphine. Ask them to attend FCPM, that is Foundation Course in Palliative Medicine called Pallium India. All the fear will go.
Yeah. We have advocated them to join this course, foundation course on palliative medicine, but the newly joined medical officers, they want to appear for the NEET exams for the postgraduate training, not to appear for the foundation course in palliative care. So hospital institution is also not giving any salary benefit in terms of the salary or in terms of the any monetary benefit. They are not giving. They are thinking it's better to do.
But if one wants to go in palliative care, you must have that FCPM so that the fear goes away, and they have to be dedicated, because palliative care is not something which is very common and which should be acceptable by all. So it has to be an inclination for palliative care.
And providing an example, a unit where people can come and watch what you do is also often really powerful, where students and junior doctors can come in and see you working with the patients, prescribing the opioids, improving people's quality of life. Often that's, the most powerful education.
Yeah, ma'am.
We need to wind up. Just a couple of comments. Could you be very grateful if you could complete the feedback? We really look at your feedback and try and take it on board in our planning. And our next session is the 12th of July. At the moment, our plan is to talk about feeding dilemmas in end-of-life care. It's possible that we might take a break for a month, but we'll keep you posted. But at this point, the plan is to meet again on the 12th of July. And I think that was all I needed to mention. But just to thank you all again for attending, and thank you to Dr. Anil and to Dr. Mukul for your presentations. We really appreciate your time, especially when you're not feeling well, Anil. So thank you very much.